I prefer to work with individuals and parents that are hesitant to give medicine than those that think that the solution to every problem lies in a pill bottle. Medicine is not supposed to be given out like candy. You know, when we marry our kids off, they are at the highest risk time for, in theory, statistically, for, you know, having bipolar disorder come out, for having schizophrenia come out. We don't know where they're going to end up. People will typically come in and they'll tell me, you know, the FBI is after me and the Mashiach.
Yeah.
Everyone's into eating organic.
Yeah.
And then, you know, they buy, you know, drugs from the drug dealer. There's the problem that they're not so transparent about it. So it's, well, you know, I'm selling the car as is,
Right.
you know, and your headache if there's a problem.
Right.
We don't do that with our kids.
What message do you have for parents who are afraid to give medication to their kids? Okay, today we have our guest has dedicated his life to understanding healing and human mind. His name is Dr. Ronen Hizami, board-certified child and adolescent psychiatrist.
An adult psychiatrist.
And you have 30 years of experience in the business? Wow. He works a lot in the community. Welcome to the struggle.
Thank you.
What we want to do is we are going, before we even start talking, we want to get to know you a little bit and find out what drew you so many years ago into this field.
So first, let's start with the riddle. First of all, thank you for having me. Let's start with the riddle. What happens when you take 1/4 Sadigur,
Yes.
1/4 Vishnitz, and half Temani?
Wow.
You get a stubborn Temani psychiatrist that likes to make jokes about gefilte fish. That's me.
Excellent. So you have Hasidish in you.
Oh yeah.
And you also have Taimani, right?
Yeah, I'm Temani.
This is a beautiful combination.
It's interesting.
It's an interesting
And the other joke is, you know, that I used to make when I was younger is what happens when you mix this, you get a psychiatrist, right? It's so it's interesting. I never thought I was going to be a psychiatrist. I knew from when I was little that I wanted to go into medicine. And it's funny because I had 2 friends that were going through school with me, and we each accurately predicted the other's fields. One of them is a thoracic surgeon today. The other one is a plastic surgeon. And when they told me I was going to be a psychiatrist, I was offended. But when I was in medical school and I did my first psychiatric rotation, I absolutely fell in love with it.
Wow.
It was the one field that I felt where the personal relationship between the psychiatrist and the patient really had a tremendous effect on the healing process for the person. You know, the pediatricians are very important. The primary care doctors are very important, but anybody can write for the blood pressure pills, for the antibiotics. The place where the kesher is so important.
The connection was like
is
beyond.
in mental health. And yeah.
And also the making a difference, you know, when you see the result and you see a finished product, the fulfillment is beyond words.
Yeah, and I'm at this stage in my career where I have, you know, where I'm treating 3 generations within the same families. So it's quite the privilege. It's
tremendous work. It's different than the surgery, and it's when a person is in a very dark place. They don't see light by the end of the tunnel, and you come in like an Atzula guy.
Okay.
You know?
I think that the biggest part, the most important part in the beginning is trying to understand what's happening and to give it a name.
Yeah.
Because when we don't feel well, if we're not opening up and we feel very dark inside, we feel like we're the only one suffering.
Correct.
And when you go to someone and they can say, you know, it has a name, it's called this. And I can't express the feeling that I get when someone comes into my office and they start to say, well, you know, I'm really not feeling well. And they speak for a few minutes. And then I say to them, do you have this and this and this and this? And they say to me, how did you know?
Yeah.
And I said, well, because this is actually very common. It has a name.
Right.
And when it has a name, we then can apply the statistics, we can apply the research, we
Right.
can
And
apply the treatment
they
guidelines.
feel like it's not the end of the world. What do you mean? I'm not the only one, and you actually have a name for it, and you have the solution for it.
Yeah. So, I mean, it's interesting because people say, why do you have to label everybody?
Right.
But the label is actually very important.
Important.
Yeah.
Wow, very interesting. So let's start. Let's start from the beginning. And this is, I have to bring in the Rabban Shalom into this. A child is born into this world. And later in life, or sometimes I'm going to ask you, this is one of the questions I want to ask you, what age, when a child is born into this world and grows up, when do you start seeing signs? But before that, this is something that I think, and I want to hear your opinion, is that there's no answer for it. Person comes into this world and the Rebbeinu Shalom gave him this gift of struggle with mental health. And there's no ifs, buts, where, when, we don't understand it. And sometimes people say it's in the genes and it's family history and stuff like that, but sometimes it skips gender. This is an answer that we don't have an answer for. This is like one of those things that the Rebbeinu Shalom gave you in your journey in your life. So when does a parent or a school or a person start seeing mental health problems from when a young child is born?
So really, it depends on the disorder that we're talking about. You know, there's this false dichotomy between nature versus nurture,
Right.
which is false because we know that it's really nature through nurture. So I'll give you an example that I use all the time. You can imagine that we're building two skyscrapers. We have the same construction crew, we have the same architecture, the same material. And we're building one of these buildings in Miami in the middle of the summer. The other building we're building in Toronto in the dead of the winter.
Right.
Even though we're using the same architectural plans and the same construction crews and the same material, the buildings are not going to be exactly the same. Marabu ma'asecha Hashem kulam b'chokhmah asita. The DNA is where we have the architectural plans to build the body. And DNA strands are very, 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 very long. So it's interesting because you get different things depending on where you start to read the DNA.
Huh.
And the environment and stress levels can affect where you start to read. So the nature is something that we're born with. Now, there are certain things that can happen that can affect our genetics, but the stress that we live with can also affect how the architectural plans are read.
You wake up something over there.
L'chora, yeah. And so then, well, how do we know what we're dealing with? So
that is nature?
Nature is our genetic programming.
Right, but for a person to have stress, to be in a stressful environment or whatever.
Even growing up in a home, that's very, very stressful. So there are reports, they call them studies, of twins that are separated at birth. Identical twins that grow up in different environments, and they come out differently because the environments are different. So again, it's, Miami versus Toronto. Yeah. The buildings are not going to be exactly the same. People say, well, why did it come out when I was 20 or 25?
Right.
And I say to them, baldness runs in my family, but when I was younger, I had a full head of hair. Right. Things tend to come out at certain ages. So, there are some conditions that we see early on. So for example, autism is something that we see early on, especially a very, very clear case of severe autism.
Where do you see it? By the learning part? By the behavior?
No, people with autism tend to have developmental delays early on. You can tell pretty early on that they're either not developing at the usual rate, and at the well visits with the pediatrician, or when they start to go to preschool, you see that there's a problem with their interactions. There's a change with how they play.
Right.
So the very, very clear, obvious cases are there very early on. But something like anxiety that can come out during childhood. It can come out
Later.
later. Something like bipolar disorder. Um, Sometimes we see simanim earlier on. Very severe cases that happen before puberty are disastrous and very obvious. But typical case, person is absolutely fine, and then all of a sudden, bam, their symptoms come out.
Usually in the teens or
So for
closer to 20, right?
So there are different times when it comes out, different peaks or spikes. In boys, the first episode is usually in the late teens or 20s, and in girls, it's usually in the 20s or even later. We have to be careful with the usually word because
Right.
statistics are not koach nevuah.
Right. Now, the few famous ones that everyone knows, the ones who are not educated in this field, but they know it, is bipolar, schizophrenia, and borderline. So can you give us a short explanation? What is bipolar? What is schizophrenia? What is borderline?
Sure. So, schizophrenia, let's start with that, is a disorder that happens, it seems to be because there's a problem in the migration of the neurons during the pregnancy. So what happens early on in pregnancy even is that you have the sperm and the egg coming together and making one cell, and that cell replicates, becomes 2 cells, becomes 4 cells. Eventually you get a ball of cells, and then eventually that ball of cells hollows out and then folds up over itself like a bubble C. It's at that point, until that point, all of the cells are identical. If you would take one of those cells off or multiple of those cells off, you would get identical embryos, twins, triplets, etc. At that point is when the cells start to differentiate, which is right when a woman notices, oops, or oh wow, I'm pregnant.
Right.
Is when the brain starts to develop, the central nervous system, I should say. And the cells start to develop, and there's a migration that happens. When it seems to be that a problem with the migration of those cells leads to some of the psychiatric disorders. So schizophrenia is from the more severe of the disorders. People with schizophrenia typically were never quite right. They're kind of off socially when they're growing up, maybe seeming anxious, not in all cases, but in most cases. And then all of a sudden, they explode out with very serious symptoms. The symptoms are broken up into 2 categories: positive symptoms and negative symptoms. There's nothing positive about the positive symptoms. The positive symptoms mean that something is there that shouldn't be there.
Right.
And negative symptoms is they're missing something that should be there.
It's like COVID, positive and negative.
No.
Yeah.
So the positive symptoms are hallucinations, which are experiencing something that isn't there. So they can hear things, and it seems like it's coming from outside their head, like my voice now, but no one else hears anything, as opposed to being something in their head, like a thought. They see things. Those are the 2 common, what we call auditory and visual hallucinations.
And this is very scary stuff.
Yeah,
very
it's
scary
frightening
stuff, because most of the time these thoughts, the auditory and they're not positive. They're talking to you stupid stuff. They scare you, and people suffer from this in silence on a tremendous level.
It's really, really quite impactful on their lives. It's debilitating. They also have delusions. Delusions are fixed false beliefs. So here you get the usual paranoia that
Fears.
comes in. Yeah. So it's a fixed false belief. So it's not something that changes.
Right.
So if I tell you, if a patient says on one day I'm 7 feet tall and they're really not, they're my size, and the next day they say that they're 7.5 feet tall, that's not a delusion. But people will typically come in and they'll tell me, the FBI is after me, and I've had patients tell me that, the government is following them and spraying them all day with poison gas.
And they really believe it. It's not a joke.
They really
in their
believe it.
life, they believe it. So you want to tell me there are people who are walking down the street, you're going to shul with those people, chas v'shulam if someone doesn't take care of it. But this guy is just sitting over there being tortured by his mind.
That's right. That's right.
That is one illness that is.
It's usually pretty obvious when someone is symptomatic. At least in the beginning, it's usually pretty obvious. And then medications can be, we'll talk about that in a sec. There's also something called a thought disorder, which is where their thoughts aren't structured the way that they're supposed to be. And there are different types of thought disorders. So sometimes their thoughts don't make sense. One thought doesn't connect to the other thought, at least to us outside. To them, it makes sense. But when you talk to them, they're not able to communicate effectively because they're speaking about things that have nothing to do with each other, at least to us on the outside. So those are from the positive symptoms. The negative symptoms are things like, not feeling emotion, not having any motivation or drive, those types of things. So Baruch Hashem, 1/3 of people with schizophrenia do very, very well with medication and can live completely normal lives. 1/3 are severely impacted and medications don't really help them much. And 1/3 are kind of in the middle.
So what do we do with those people who are severely affected and the medication does not do the job?
So we do the best that we can. There are, in addition to medication, there are other treatments, and they get a lot of support within the community.
Well, they suffer. They suffer immensely.
Miserably. Yeah, and there are other treatments like shock therapy that can sometimes be helpful. Right. But it's a frightening thing when it happens. So, even more frightening is when people get misdiagnosed with schizophrenia and they're really suffering from a medical condition. And those cases come up every once in a while. There have been, I've had cases in my office that have come in where someone legitimately had Lyme disease and the diagnosis was missed. There are cases where people have seizure disorders. It doesn't happen commonly, but there are cases also people have rheumatological diseases that are completely missed, not diagnosed, and people end up really not functional, losing decades, end up in living in community residences. It's really frightening what happens sometimes.
Now, what you're saying is that this is in the genes?
So this tends to run most things, the vast majority of things run in families. It's not 100%. So if someone has a parent that has schizophrenia, it's not a guarantee that their child is going to have. And we don't have all of the genetics quite figured out because there isn't one specific genetic process that explains most psychiatric disorders. So when you look at population studies, which are not perfect, you get a sense. But there are families where there are multiple members that have this disorder or that disorder. And some families where it just seems to pop up and there's one person. Now, of course, with the Holocaust, our family histories were chopped off at the knees.
And why? Because of that? Because we lost people.
We lost so many people
and records. We lost the communication.
Forget first that people don't talk about these things, and the field of psychiatry was really
was not a subject.
Wasn't really makubal back then.
Right. So with the work, it's hard work now to start from fresh and start making statistics and holding records, and so there's double the work.
Well, it's an interesting thing because there are it happens in my office quite frequently that people will tell me that they have no family history of anything, and I know more about their family history than they do, and I know that I'm treating multiple.
Also, because families don't share.
They don't share.
Parents will not share with the kids, which is a crime for itself, and then this is not a subject. This is something that is so taboo. There's such stigma even in your own family.
Yeah, and how do I know that they're the same? Because the same grandparents are paying for the kids, So, so that's schizophrenia.
That's schizophrenia and bipolar.
So bipolar disorder is interesting. The way Hashem created us, it's normal for us to have a range of emotions, right? If someone doesn't feel anything emotionally, that's a different type of problem.
Right.
But there's a limit. So even if something bad happens, there's a limit to how down you get. So even if something good happens, there's a limit to how good you feel. Yeah. So some people have leaky borders, like the United States now, right?
Yeah.
So there are some people that can get stuck at extremes of mood. When there are some people that just get stuck too low, we call that depression. There are some people that can get stuck too high or too low. We call that bipolar disorder. Now, bipolar disorder, like everything else, runs in families, and people can typically have completely functional lives if they take care of it. We have great medications that help to keep mood steady for most people. The challenge is that many times they go off medicine, they're feeling good for a long time. So of course they forget one time and they say, gee, I was fine. And then they say,
don't understand that this is the medication that did it.
That's helping to keep them steady.
Right.
So the high of bipolar disorder comes in two forms. There's something called hypomania, which is not as bad. And then there's mania, which is extremely debilitating and can be life-threatening. A person has to have an extreme mood elevation, which can be being euphoric or too happy, or extremely angry or irritable. When they get like that, one of the things that happens is that they will typically be involved in pleasurable things with poor judgments. So I've had patients that signed up to join the military when they've been like that, and we had to fight to get them out. You can imagine that someone can become hypersexual and without a cheshbon. So there are interesting shilas that come up, if there's a married lady and she's manic, and then she ends up going out, and maybe it's not so obvious at home what's going on in the beginning, and before you know it, she slept around, and what do we do? How do we look at that? So it opens up all sorts of shilas and problems that, but people, if they lose their judgment and they do things that are pleasurable, so people can use extreme amounts of substances that are very dangerous. I've had patients walk miles and miles and miles through bad neighborhoods without even thinking twice when they're manic. So obviously they're opening themselves up to danger. Right. So other symptoms that can be part of mania are speaking much faster than usual. Sometimes you can't even get a word in because they just speak so fast.
The mind is racing.
Yeah, their thoughts can race. They don't need to sleep so much. They can be working on 2-3 hours of sleep. So mania is considered an emergency. And of course, people with bipolar disorder have a higher rate of suicide. Bipolar disorder needs to be taken very, very seriously.
Because you can hear always couples, between couples who are fighting or whatever. It's, she had bipolar, he has bipolar. And can you live with bipolar without being treated or no?
No.
Very difficult.
No, it's bipolar disorder is a recurring illness. And people that don't take care of it, if a person is manic and they don't take care of it, after a few months, they tend to burn out exactly the way it sounds. And I mean, they can't avoid taking care of it unless they're living by themselves on a desert island, because they become so symptomatic and unable to care for themselves. And sometimes they can become psychotic. They can have symptoms of schizophrenia as well.
Right.
One of the interesting symptoms is that they can become grandiose. And I have had many times when people have come into my office telling me they're Mashiach, telling me that they're Eliyahu Hanavi, telling me they know exactly where the 10 Lal Shavatim are. And so it's Nebuch.
It's serious.
It's serious stuff. And sometimes they can be fun to be with. They can be the comedian that brings the room down, make everybody laugh, but it's a frightening disorder and needs to be taken very seriously. So most of the time, you can't tell that someone has bipolar disorder until it explodes out. There are some cases where you can kind of see it when they're younger, but those tend to be the more serious cases. And then you asked me about borderline personality disorder. So let's talk about personality disorders in general, because everybody knows about borderline, but there are other personality disorders too.
Correct.
So in the most simple of terms, a personality disorder is when there is an impairment in the way a person does business with the world and themselves. That's the simple. And then there are different flavors, like there are different flavors of ice cream. Borderline personality disorder is the most well known. It used to be a nice insult to say this person is borderline, that person is borderline. It really can be quite debilitating. People with borderline personalities struggle with their identity. They will frequently be involved with self-injurious behavior,
Like
as opposed to suicide.
like
So cutting and burning.
and what about anorexia and all this stuff?
They can have those symptoms as well. They can have brief times where they become paranoid. They can become extremely moody, and they tend to go from loving people to hating people. Quite debilitating. There are more symptoms too, but it's quite debilitating, and medications don't help as much for it. We can smooth the edges out with medication, but there is a very, very effective modality of therapy called dialectical behavior therapy, which if people really take it seriously, can be quite effective.
What kind of therapy is that?
So dialectical behavior therapy was designed by Dr. Marsha Linehan, who's a psychologist in Seattle. She was working in a psychiatric hospital on an inpatient unit, working with women with borderline. And at the time, she was into Buddhism. I've heard since then she was into Kabbalah, and I'm not sure where she's holding now. And what she did was she took some of the principles of Buddhism, which are not unique to Buddhism. They exist in every organized religion, and basically formulated a plan. So what it involves is two separate components. There's a didactic component, which according to the program is done in a group setting, where people learn certain skills. So you can think about it as, I remember when I was growing up, there were posters that said everything I ever needed to learn in life, I learned in kindergarten. And then it says like how to say please, how to say thank you, how to share, right? So the skills you can think of as being mashlim et chaser. They teach people how to have relationships. They teach people how to live in the moment. They teach people...
They teach the borderlines.
Yeah, well, we use it for a lot more than just borderlines today. They teach people something called distress tolerance, which is exactly what it sounds like. They teach people mindfulness.
So that has nothing to do with medication.
Nothing to do with medication.
So physical, and does medication help them to sit on the chair at least, or you don't need that?
So medication can help with some of the moodiness, and it comes to the point of medication in general, which I guess we'll talk about in a minute. But so basically, they go through this didactic part. So they have once a week typically where they're going through the didactics, and the didactics are taught in modules, and then they also have a typical one-on-one therapy session as well, where they're, in addition to the usual stuff that happens in talk therapy, where they're taking from the klal of the didactics and bring it into their prat. So it's quite effective, and it's kind of like ketchup today. You know, you can imagine that ketchup was designed for French fries, but it's used for just about everything today except ice cream, right? So DBT today is used for addictions. It's used for eating disorders. You know, we use it for lots of different things. Now, it's interesting. Marsha Linehan's chiddush wasn't in the skills. The chiddush that she did was just basically in how she structured things. So it's quite effective. And, you know, also sometimes, while we're on the topic of borderline personality disorder, you know, you say tomato, I say tomato. There's this sugya called chronic PTSD, where sometimes people have been through a tremendous amount of trauma. And they look like they have borderline personality disorder. Essentially, they're treated similarly in some aspects and not always. So if you want now, I can answer your question about medication.
Yes, because the question is, all these three that you were saying, bipolar, schizophrenia, are treated with different type of medications, which means the medication does something to for the brain that everything has a different type.
So not exactly. We'll use similar medications for different types of problems. Sometimes same doses, sometimes different doses. One other key component of a personality disorder is that it doesn't just pop up suddenly in adulthood. it has to have been there from adolescence. And it's one of the mistakes that I see a lot of clinicians making is that they'll very quickly make a personality disorder diagnosis without, let's say someone comes in and they're 40 years old and they'll have a pattern that's consistent with one of the personality disorders, but they forget that the symptoms have to have been there from adolescence. And if these types of symptoms present all of a sudden later on in life and they weren't there before, it's something else.
Yes, yeah.
There's almost no symptom in the field of medicine, not just psychiatry, that's pathognomonic. Pathognomonic means that the symptom equals a diagnosis. So if someone comes in with symptoms of ADHD, sometimes it's ADHD, sometimes it's something else. Someone comes in with symptoms of psychosis, sometimes it's schizophrenia, sometimes it's something else. Someone come in with symptoms of a personality disorder, sometimes it's a personality disorder, sometimes it's something else. And this is really where some of the art in psychiatry comes in, is really trying to figure out exactly what's driving, what's the engine that's driving this.
But it's also throwing darts sometimes. We are at the mercy of a doctor sitting over there and trying to help you and figure it out. And he tries one, it doesn't work, you go off, he goes on another one. Is that the process?
So we don't know lichatchila which medicine is going to work. And even before that, we have to have a realistic and reasonable expectation of what medication is going to do. We don't always use medicine. It depends on the condition. So there's a whole cheshbon that goes into first understanding what's going on, establishing whether there's even a diagnosis or not. If there's a diagnosis, then okay, well, what are the treatment guidelines? Now, treatment guidelines are guidelines. We're allowed to deviate from them when we feel that it's appropriate. We're not robots. But anyone who guarantees that a patient is going to improve with this specific medicine is lying or is a fool. I'll give them a better price for the George Washington Bridge and throw in the Verrazano for free. We don't know. There's a lot of trial and error, but it's an educated and informed trial and error. Medication response tends to run in families. So here's another kunz with when families aren't open with each other. It can really affect treatment.
Of course. Now let me ask you something. There is a couple who got married, and they're marrying young. Couples today are marrying very young. In their 20s or their mid-20s, it pops up. One of them just woke up the monster. Something came out. What does this other spouse supposed to do? How is that other spouse supposed to deal with this situation? And is there hope? From your point of view, what would you say to the spouse? Just, we're in good hands. We'll try to help him, and we'll put him on this medication, and they will be a productive member in society.
So I never tell people what to do in those situations. I can't make a decision for someone. I've actually had several instances where people became manic for the first time right before their chasana or during Sheva Brachas.
Wow.
And it's frightening because you marry someone, they have no history before. There's nothing in the family. In these cases happens to be there's nothing in the family. And all of a sudden, the person becomes extremely symptomatic in a very, very obvious way. It depends on the diagnosis. All we can do from the psychiatric perspective is try to stabilize the patient, try to educate everyone about the statistics. There are some people that stay, there are some people that go. It's a very, very individual decision, and it's always very, very sad. People don't choose to be sick.
Right.
And, people don't choose necessarily to marry someone who's sick unless they were told in advance, right?
Yeah.
So it's always heartbreaking. The good news is that with most conditions today, we're able to stabilize the person in many cases. And depending on the diagnosis, most people go on to live a very happy, productive life. The more severe disorders that really impair functioning, they tend to show simonim before there's something unusual there in many cases. So, but it's always very, very sad.
It's heavy stuff. Heavy stuff.
Yeah.
I would want to talk about suicide. Lately in the community, you see young and you see women, you see middle age. Lately, it's been more talk about it. We've seen cases that is frightening. Suicide. What is the suicide? What is going on in these people's heads? Is it similar to what we spoke before, that they get messages in their head, or is it just life? They don't see light by the end of the tunnel. They're not positive, or is it something that's out of their control? And to actually go and do it, this is not easy. People just think you throw yourself off a roof, off a bridge. What is going on with the suicide?
So it's interesting. I'm going to tell you something that may shock you, is that until recently, I hadn't heard that there was such a spike in suicides. Until I heard a lot of people starting to talk about it. And then I had one not very long ago in my practice as well.
One of your clients committed suicide?
Yeah.
Mm-hmm.
When there are some psychiatrists that before you make an appointment, they talk to you on the phone. And if it sounds a little bit too complicated, they don't want to be bothered. I wasn't trained that way. I'm here to help. And when you treat people that aren't well, you are not always matzliach. If you cherry pick, the heart surgeons that just take care of the gentle, mild cases, they have 100% success rate.
Right.
It's the ones that take on the challenging cases that are not going to be 100%. So I've had my share of suicides throughout the years, and there are some that still to this day, I scratch my head and I say, after 120 Kodesh Baruch Hu, explain it to me, please. There was one that I still remember where I was when I got the call. And I had to meet with his wife afterwards. And it was one of the most difficult meetings that I've ever had, not in my career, in my life, because I had no answers for her. It was very, very sad.
There is no answer. I had a friend who also committed suicide. And I don't know, I knew he was struggling, but he never spoke about it. And one Sunday morning, we all heard the news. And I was always wondering, what is really, is it at the ledge? What is the drive? What's behind this, that they actually take action like that?
One of my supervisors in residency taught me something that isn't entirely true, but I think it's true to a degree. He said that people that are connected to other people don't kill themselves. Now, it's not entirely true, because there are people that act impulsively, even if they're connected to other people. There are people that are psychotic. There are people that are intoxicated. There are people that could be having a flashback to some trauma. We just don't know. It's hard to do a study to ask people after they've committed suicide, to send them a questionnaire and say, hey, what made you do it? We know there are certain conditions that are more likely to end in suicide. There's an increased risk. What's really frightening with depression is that the highest risk time with depression is not when people are in the pits. It's when they start to get better, when they are severely depressed and they're in bed and they can't move and they can't do anything and they haven't bathed in we don't know how long and they're barely eating. They don't have the koyach to do anything, but when they start to get better,
after the
exhaustion, that highest risk time. And I think that's what happened with that patient that I mentioned before that I'd like the answer to. But it's frightening. I don't know that anyone can quite answer. And, as a field, we're not very good at predicting was going to take their lives. There are risk factors.
Right.
Family history is a risk factor. Certain diagnoses are a risk factor. But the biggest risk factor is a prior attempt.
Yeah.
And, I tell people that being a psychiatrist is not a 9 to 5 job.
No.
My cell phone is always on.
Yeah.
I tell people, except when I'm on a plane, and actually I flew to Eretz Yisrael back in December for a few days for a chasana. And so I'm on El Al, it's the only airline that's flying. And I paid for the internet because I had to get some work done. And so I had my cell phone connected and my laptop connected, and I did what I had to do. I shut it off. I forgot to disconnect my phone. And wouldn't you know it, I was just falling asleep. Everybody was sleeping. All of a sudden, my cell phone goes off and someone was calling me with an emergency. It's not a 9 to 5 job, and we have to make ourselves available to people that are truly in crisis.
Unbelievable. So what you're saying is that, and it's very important, loneliness is something that will drive someone to suicide.
It's not just loneliness, it's the lack of connection. I mean, with COVID, we learned about not just the mental health costs, but the regular physical health costs of isolation. And isolation is different than loneliness, right? With it not having a connection, right? So you can have someone that has relationships, but during COVID, when we were all locked down, if there were people that were by themselves and they weren't going out of the house, even if they have a kesher, it's not the same. They're all by themselves, and it led to horrible things. And all these heterim to, for people to call hotlines and stuff if they were feeling like they were struggling on Shabbos, on Yantif. It wasn't an easy time.
What do you think that they feel they're alone?
Sorry.
What do you think about to conquer loneliness? Even though I know we're just, we're not Rabbonim and we're not in this business, but for someone to connect a little bit more to, in addictions, they talk about higher power and they talk about, but as Yidden, we connect to the Rabban Shalom. And if we put a bigger emphasis on these things, would that help for a person to feel connected? Because to rely on friends and to rely on other people, where that ends up. But if you put yourself, if you take a few minutes and you try to go down that avenue of connecting spiritually to the Rebbeinu Shalom and live a meaningful life a little bit, would that help for people who suffer? I mean, for regular people, for sure it's going to help, but even for people who suffer from loneliness.
The question is very dangerous because so first of all, of course, it can be helpful for anyone to connect to Hashem. But the flip side of your question, someone could read between the lines and say, the reason that I'm suffering is because I have shvera midos, and I don't believe in Kadosh Baruch Hu enough, and if I only did this or that. Would we say that with someone with heart disease? Would we do that with someone that has high blood pressure? We're talking about illness that's no less physical than anything else. And actually, I was invited to the Kirov Tuni Shabbaton.
Right.
And one of the things that I gave 4 talks there, and one of the ones that I gave was, how do we distinguish between a problem with midot and a psychiatric diagnosis? And it's a whole sugya, but illness is illness.
Wow.
And so we have to be careful because a lot of times people will come in and say, maybe I don't need treatment. Maybe I just need to learn more. No, certainly working on your emunah b'tochen is helpful, but you have an illness and you still need treatment too.
Right.
I don't make believe that I understand why Kadosh Baruch Hu does what he does. I know what he does is always for a reason, and I know that it's always for our benefit. And I tell everybody, it's our job to make our hishtadlus. Kadosh Baruch Hu decides what works and what doesn't work. And sometimes he makes us look like fools as clinicians.
Right.
And sometimes he makes us look like we're really smart. But at the end of the day, he's in charge.
Right.
It's interesting. I learned I think it was in Midrash Tanchuma, I don't remember in which parsha, that it says 40 days before conception, Hashem sends a specific angel to the repository of neshamas, and it summons the neshama, and it's announced 40 days before conception if they're going to be rich or poor, what they're going to do for a living, where they're going to live. Are they going to be smart or not smart? Are they going to be healthy or not healthy? So, I assume that mental illness is part of that. And everything is a cheshbon. I'm not going to make believe that I know why. Certainly, buckling down and talking to the boss is always helpful, and working on our connection with Kadosh Baruch Hu is always helpful. Yeah. But with both feet solidly planted on the ground, we have a chiyuv to take care of illness, and that involves getting treatment.
So let me tell you what I'm hearing from you. What you're saying is that Amina, Betuchen, and Mrs. Forum, this is all gorgeous and important
for everybody.
But what you're saying is that this illness that you're talking about, that you're treating, and this is nothing different than any physical illness. So that means if a person is suicidal, is because there is something in the brain that gives him wrong messages.
There's something going on. Yeah, there's something going on, not just for suicide, for everything.
For everything. So bipolar and schizophrenia and all these things. Because it's clear that if someone has schizophrenia, you're not going to tell him to go sit down and, take a Missa cipher. He just sees Aliyah Novi. I mean, he's not here.
That's how the field looks at it.
That's how the field looks at it. This is saying that these people have a problem. It's a hard problem. Nothing different than any different.
Yeah, so when you do studies using very fancy imaging techniques and look at the electrical activity in the brain, we see that there are differences in people that have certain psychiatric disorders versus people that don't. So there are physical changes in the brain that are associated with these things. Right. It's not, ruach ra'ah that's overtaking the person and or something that they're making up. There's a legitimate physical problem that's presenting in this way.
Right. So you were saying before, do you think that trauma is something, if a person was a totally healthy person and they're going through a very horrible time, whatever the case is, sexual abuse or any other, could attribute to wake up one of these mental illnesses that we discussed before?
It can certainly contribute. And we also know that there are genetic differences between us. There are some people that have a greater likelihood to respond with greater difficulty to trauma than others. Mm-hmm. So again, people say, is it genetic? And I say to them, I challenge you to find something that isn't genetic to a certain degree.
Now, as far as addictions, I want to talk about addictions. Now, they call it a disease. It has all kinds of names. The question is, addictions is an illness, or addictions is something that has to be treated? And I'm talking about alcohol, sex addictions, all these type of addictions falls into which category?
Yeah, they're diseases. We know that there are certain people that have a genetic predisposition. Addictions run in families as well.
Right.
Sometimes there are conditions that have a greater likelihood of having addictions associated with them if they're not treated. And politics aside, we know that addictions are diseases as well and require treatments.
And is there medications? Because I know there are some medications that the doctors treat alcohol. I mean, it brings a little bit down the urge for alcohol and for addicts and for sex addicts. Is there something that...
So there's no medication for sex addiction officially. There are medications that we use that can be helpful. Mm-hmm. There are medications that are approved to help treat certain chemical addictions. But medicine is never the answer. It's part of the answer. Mm-hmm. Yeah.
Because what you're saying is that to treat addictions and all these other stuff, that needs a lot of talking therapy as well, and that needs a lot of self-help. That is not just clear-cut the way the other mental illnesses. This is a combination of the two.
Yeah, I mean, it's not the only disorder that also needs therapy, but just medication is typically not going to work.
Now, I want to talk about weed. I want to talk about the drugs. The young people today, it supposedly is becoming normal because it's legal now. You know, it's like alcohol. But how dangerous is weed? Because what I read is that weed can flip you over. Sometimes if a person has something in their head, sleeping, weed will do that for you. And people think it's a joke.
So if people walk away with nothing else from watching this podcast, just what I'm saying about marijuana now, I'll be happy. Marijuana is incredibly bad for you.
Wow.
Now, let's talk about it for a second. You know, my parents' generation, people smoking for decades. They seem to be okay. Maybe they're a little bit more stupid,
Right.
but no.
They're okay.
What people don't realize is, number one, the cannabis that we use today, that's available today, is much, much more potent than the cannabis from prior. So when someone takes a certain amount of marijuana today, it is much, much more powerful gram to gram than what was used 10, 20, 30 years ago.
Right.
So it's much more dangerous. We also know that in some individuals that have a predisposition for certain disorders, like schizophrenia, for example, marijuana can bring it out earlier. We also know that there's a process that happens in the developing brain. So before, when we started, we spoke about when the brain starts to develop, the very beginning of pregnancy.
Right.
That process continues typically, you know, to the mid-20s. One of the later stages of brain development is something called apoptosis. Apoptosis is a pruning out of pathways in the brain that aren't needed. They're not used, and it starts way before, but there's this kind of finishing up of the process. Marijuana use in kids and teenagers and very young adults can affect that process permanently. Once the brain is done, it's done. You can't fix it. At least we don't know how to fix it. So if I were, and I'm happy to say that I have never in my life used any illegal drug,
Right.
But if I were at my age to use cannabis, it wouldn't have the same effect on my brain because my brain is completely developed. If you give it to a teenager, it can cause permanent harm.
Wow.
We also know that in people my age and adults in general, it increases the risk of all sorts of heart conditions, increases the risk of stroke. I mean, it's what I like to call bad news for the Jews.
Wow.
Now, just like many other plants and substances, there are positives. So there are certain medicinal uses for cannabis. But that cannabis is tightly regulated and it's all in the dose, right?
Right.
There are certain substances that can be quite effective. If you take too much, it'll kill you. And if you don't take enough, it's not going to do anything.
Right.
So there are conditions for which it's quite helpful. But it is...
You're talking about the ones who they're selling on the streets for young kids who don't even know where it's coming from, where they're buying it from.
So that's a bigger problem because... But I'm talking about even the stuff that's grown and purchased in the dispensaries is still dangerous. The real risk of the stuff that's sold on the streets is that many times there are very dangerous things that are mixed in that are much more dangerous.
Yeah.
Like formaldehyde, like PCP, which can cause permanent, severe damage. and it's just staggering. I mean, everyone's into eating organic, yeah, and then they buy drugs from the drug dealer, and they don't care about all the pesticides and all the things that are mixed in that are even more dangerous than the marijuana itself. And they say, "Oh, I don't want to take medication. I'm against medication, but it's okay. I'll use illegal drugs. That's fine."
It's unbelievable.
Or even legal drugs, but not in the right way, not for the right indication, and certainly getting it in a way that's dangerous. So I think this fallacy that marijuana is safe because it's legal is
false.
you might as well say that the internet is completely safe too, and pornography is safe and everything is safe when okay, thank you.
Now, what's your take on psychedelics?
So I'm not an expert in the field, and I have a problem with the way that it's being used today. I appreciate that there may be a role for certain psychedelics, but I'm not a big government guy. But when it comes to making sure that the things that we take are safe and consistent, like with medications, I'm a huge fan. And when something isn't regulated as a medication, you don't know if what you think you're getting is what you're really getting. A. B. The psychedelics, just like we spoke about with marijuana, or just like any other medication, are certainly helpful. The data demonstrates that some of them are helpful. But we have yet to establish clearly at what dosage, for who should be doing it, what training do they need. And it's the wild, wild west today. And so in theory, I don't have a problem with it if it's done properly. But, there are patients of mine that, they want to try ketamine because they heard it's a nice thing to do. And they end up in a horrific place, let alone some of the other psychedelics that are out there. Again, I'm not questioning that there are benefits to them, but it needs to be studied. It needs to be done properly by people that are trained. And I'm not talking about the drug companies having control over it. That's a whole other sugya. But we want to make sure that we're not hurting people more. And, there's this sugya of taking advantage of people that are struggling, or people that have kids that are struggling. I'm afraid that a lot of these centers that open up that are doing illegal things, I mean, psychedelics are illegal in most states. There's a bit of taking advantage of patients. And I've seen that with some of my patients that have, kind of gone to some of these IV ketamine centers, and they walk in and they BS their way through the questionnaire, and they have a BS screening. And some of them have very bad outcomes.
Yeah. And why do you think people are running to these places? Are they running away from themselves? Are we coming back to the same idea of people not being fulfilled and not being content? And I'm not talking about mental illness. I'm just talking about people who experiment these things for recreation or for other reasons.
I would be careful to give kind of one explanation. I think there are some people that are curious. I think there are some people that are escaping from life. People escape from life in lots of ways. Sometimes it's drugs. Sometimes it's the internet. I mean, it's... there are lots of escapes, and there are some that are more dangerous than others.
Let me ask you a question about psychiatric hospitals, mental health institutions. When does a person know that it's time to admit somebody to a mental health institution? And is it bad? Is it a scary place? Can you walk us through what is really happening in a mental institution, and is the patient benefiting of it immensely?
So the general rule is that we like to treat someone in the least restrictive environment. When I went into the field 30 years ago, my supervisors were telling me about, the heyday, the golden days of psychiatry when people would go into the hospital for a few months and have intense therapy every day, and they would come out different. When I
Therapy, you're talking about talking therapy, you're talking about, because all the, what supposedly what they're doing is they're just giving medication.
So it's different today, but back then, people would go in. Medication back then wasn't what it is today,
Uh-huh.
and people would go in and have a lot of therapy, and they had time.
But they used to be locked in, though.
So not always.
It was a volunteer type of thing.
Yeah, yeah, and there were some units that were open and kind of like a country club type of setting, um, and um, and they had time to really get better. When I went into the field, it's the beginning of managed care, and my supervisors were complaining that people were in the hospital just for a couple of weeks until we stabilized them with medication and we were doing some therapy. Today, hospitalization is primarily when someone is a danger to themselves or others for rapid medication stabilization, and then they get discharged to, if relevant, to a more intensive outpatient program, and they kind of step down eventually back to regular treatments in the community. So, there's not necessarily a lot of therapy happening today. I mean, I haven't worked on an inpatient psychiatric unit in decades, but I hear from the rare patients that I have to send into the hospital, it's usually not a very pleasant experience. It's usually locked in today. The insurance companies will only approve if a person really, really needs to be there.
What is the average length of a patient usually?
I don't know, since I don't work in that setting anymore. I can tell you from my rare patient that goes into the hospital, it's usually just a few days, unless someone is really very, very sick. Then sometimes it can be a few weeks. I mean, by definition, regular hospitalization is until 30 days. If someone needs to be in the hospital beyond that, then the way it used to be, and I presume it's still the same in New York, is that they get transferred to a state hospital for what's called longer-term care.
Right. So when do you find that you need to send the patient then? Is when a person refuses to take medication, or a person thinks that I don't need it? When is the appropriate time?
If a person is a danger to themselves or others. Now, a danger to themselves can be not being able to take care of themselves, right? If they can't meet their basic needs, that could potentially be a reason to send them to the hospital. But it has to be very, very clear. If someone is very aggressive to themselves or to others, if someone is threatening suicide, that's another reason.
Right.
But it's quite limited today. It's not easy to hospitalize someone, and a person can go into the hospital voluntarily, even today, or they can be forced in involuntarily. There are different legal mechanisms with which to do that, but it's not done lightly. It really takes a lot of careful deliberation before sending someone to the hospital.
Right. And let me talk about people with not such severe mental illnesses, just anxiety and stuff like that. And there's these famous drugs that everybody knows about, Xanax and Zoloft, and this is for depression. These are fully functional people who have families, and their lives are not, they run decent lives. But sometimes doctors, the word on the street is that doctors push a lot of these medications. They push it on teenagers, they push it on kids, and they push it on adults also. You don't feel good here, take a Xanax, Zoloft, and stuff like that. What is your opinion about? Is it a temporary? Is it a long term? Is it a sleep medicine?
Ambien?
Thrown around like, So what's your opinion about those?
So let's talk about medication and the sugya of medication in general to help understand the answer.
Yeah.
So I'm going to tell you a tiny little secret, as long as you promise not to keep it a secret.
Okay.
And that's that, with very rare exception, not just in psychiatry, but in the entire field of medicine, medicines don't fix.
Problems.
They alleviate, meaning everything is a glorified Tylenol. When you take it, it helps. When you stop taking it, unless you changed something, the problem's going to come right back. So if we have someone that has someone who's overweight and they have diabetes and they have high blood pressure and they have, all the typical problems, they have high cholesterol, the problems that typically go along with being very overweight. So let's say we put them on blood pressure pills. Well, okay, so let's hope the medication works.
Yeah.
And what happens if they go off the medicine? Well, unless they lost weight and changed the way that they eat and followed the instructions that they were given and that they worked, if you stop the medication, the blood pressure is just going to shoot right back up again. Right. It's the same thing with psychiatric disorders. So we have to be reasonable and realistic in our expectations of the role of medications. So if you take a look, for example, at anxiety disorders, the research is pretty clear. There's a modality of therapy called cognitive behavior therapy. Cognitive behavior therapy, whether it's OCD or whether it's some of the forms of anxiety, is quite effective. Cognitive behavior therapy teaches the person how to manage the symptoms on their own. And it can be equally effective to medication, depending on the disorder. So it takes a little bit longer to work than medication, but the standard of care is not necessarily to give someone a medicine for anxiety. So then when do we give medicine for anxiety? So the research shows that even though medication and therapy in that circumstance are equally effective, you get a much more robust response when you do both. Mm-hmm. Okay, so it doesn't mean I have to give medicine.
Right.
So if someone is able to function and they're able to participate in the therapy, go for therapy first.
Right.
But that means you have to see a proper licensed, trained therapist. And you actually have to do what the therapist is telling you. It's like taking a course, CBT. Right. So if a person isn't able to function or the therapy isn't working because their symptoms are so severe, for example, or they just may not be a cliché lakabel for the therapy to work for them, those are circumstances in which we'll give them medicine, but we're always looking. It's like an elevator. It doesn't just go up.
Yeah.
It's also supposed to come down in many people.
Right.
And a lot of practitioners forget that. Mm. So medicine is not supposed to be given out like candy. I think there is a lot of irresponsible prescribing by lots of doctors, unfortunately. There are diagnoses where, schizophrenia requires medicine.
Right.
ADHD requires medicine, especially in kids. Are there modalities of therapy that can be helpful for certain disorders? Sure. Someone with bipolar disorder needs medication.
Right.
But it's usually not just medication. There are other things that go in, and there are times when we can go down with medicine. Sleeping medications in particular can be addicting. I can tell you that I can count on one hand the number of patients that I've prescribed Ambien or similar medications for. I do not prescribe them. Also things like Xanax, I very rarely have to prescribe them.
Well, this is torture not to be able to sleep, to twist the pain all night.
I help people to sleep it with things that aren't addicting. Mm-hmm. I had a supervisor in residency, God bless his soul, who would tell me, when you start your practice, make sure you give patients Xanax because they're going to have to come back. And I said to him, my patients are going to come back without me putting them on Xanax. Mm. The name of the game is to help patients, not to get them hooked.
Right.
And to this day, I'm not sure if he was serious or joking. He was a big joker. I hope he was joking.
Yeah. But it's harsh.
Yeah, it's more than harsh. It's actually unethical.
It's destructive. Yeah. Now let's talk about stigma. Stigma in the community probably coming down. It's coming down a little bit, but I wonder if you can eradicate this thing completely. I was just talking to a person who has a therapy center in Brooklyn, and he was saying that even when you come into these offices, you have these little cubicles with these curtains, and you hide the people. You're actually showing them that there's something to be hidden here. It's a secret, and he's trying to do an open floor plan. Everybody comes in, we're all here, what's going on? This is nothing. So it would be beautiful in a perfect world to get rid of the stigma, the shame, and there is so many people suffering in silence, and nobody wants to talk about it. It's like the elephant in the room. But when it comes to shidduchim, especially in our community, it's very, very tough. And why it's tough is also what you described in the beginning. You were saying about that this is in the genes, family history. And what do you expect from people? They're petrified and they're trying to make all the research in the world, although nobody knows anyway, and nobody's throwing it under the Rebbeinu Shalom. And if you end up in one place and you end up there because this is how it's meant to be and this was your journey in life. But to remove the stigma and when you're dating, you don't even know if a person goes out and they're dating. You have no idea what their family history is. What is your opinion? How would you improve? What is your 2 cents when it comes to stigma and shidduchim, and how should one go about it?
So there's been a clear movement in the right direction when it comes to stigma. There's a much greater acceptance, sometimes even too much. There are chadarim that, if you ask the Hanhala, 98% of the kids have ADHD because they send so many kids for evaluations and treatment. And they forget that kids aren't necessarily meant to be sitting. They aren't meant to be sitting like robots all day.
Right.
But there's been a clear improvement. It's not something that's going to happen overnight. We have to continue to very, very slowly chip away and help people understand that even though psychiatric disorders present differently than most medical conditions, they're just as physical. The shidduch business is a whole other sugya, and it's a pet peeve of mine. Let's leave aside the halachic part because I'm not a rabbi. But there's a lot of game playing when it comes to shidduchim. And, I have a patient that just sold his car. I actually just sold my car as well. I got into a different car. And my patient told me that, he had this car and he had a shaila. He was selling it to Carvana, whether he could tell them that, it has transmission problems or not. And he asked his Rav, and his Rav showed him the Gemara, Shulchan Aruch, and he said, no, you have to be open, just because you're selling to a guy, you still have to be straight. Okay. Shidduchim is not selling a used car.
Correct.
And it is on many levels problematic to not be open. And I think the message we're giving our kids is so horrible, our kids that suffer with mental illness. I have multiple times a week when I am on the phone for a shidduch call, whether it's about one of my patients that's in shidduchim, or whether it's speaking to a shadchan or a rav who wants to clarify the implications of a certain diagnosis, potentially on a person's ability to live life, as it pertains to a shidduch. And what we're forgetting here is that we're taking our child and we're trying to help facilitate, if not arrange, the single most important relationship that they're ever going to have in their life. God willing, just once going to happen, to get married, and it should be wonderful and last until 120. But we're doing it in a disingenuous way. So we're taking this very important relationship and we're building it on a foundation of sheker when we're not open. That's A. Even worse than that is what's the message we're giving the kid.
Wow.
Here we have someone who, if they're going into shidduchim, vast majority of the time, they're stable. or it's as good as it's going to get. We'll put it like
Right.
that.
Right.
And so if they're seeing me about it, then they're on medication, and they've very likely been in therapy, and they've fought through, and they've built a life, and they're recovered to a certain degree. And when the parents aren't open, what are we telling them? Are we reinforcing the sticker that says you're defective?
Correct.
What are we doing? You know, when I have these conversations about shidduchim, so when I speak to the other person, many times they don't know what to ask. And I treat it like a deposition. You know, I have to say the truth,
Right.
and I answer what they ask, and I don't help them.
Right.
And they'll say to me, well, if it was your kid, and I'll say to them, you know, first of all, I can't answer that because my frame of reference is very, very different than yours. It takes a lot to get me excited. And, but, you know, when we marry our kids off, they are at the highest risk time for, in theory, statistically, for, you know, having bipolar disorder come out, for having schizophrenia come out. We don't know where they're going to end up. We don't know all of the, you know, not everything has come out yet.
Right.
And we're you know, gonna go ahead, start life. I said, we don't know what the genetics are. We can't control for them. You think you know the family history, many times you don't. And even if there's nothing in the family, it can still come out.
Also, yeah.
But what do we know? I say, and I tell people, you know, you can divide the world up into two categories. There are those that take care of their problems and those that don't. And if I'm on the phone here, you see that this is a kid who comes from a family that doesn't ignore their problems. Something comes up, they go for help, and they take care of it. And they're being open and transparent about it. I said, most of the time, 20, 18, 19, 22, 23, whichever community you're looking at, you don't know much about them yet. They're not tested by life.
Right.
These kids are tested, and the vast majority are coming through bumps and bruises, but they're showing that they take care of business. They can handle adversity. And there's something to be said about that. But we have to be careful about the message that we give.
To the children.
To the children.
But let me ask you a question. Should the parents, of course, I understand what you're saying, that the support and the validation and understanding that this is nothing more, like you call it, a physical problem. Because physical is accepted by us.
Well, it depends.
Everybody.
Some things yes, some things no.
There are physical problems that people hide.
Sure.
Also.
Sure.
Yeah. But normally if someone wears a cast, nothing is, you're good. But I understand the support part. But what do you feel about sharing it before a shidduch? If someone knows there's something going on with the child, this is a child's history, should they share?
So that's a halacha shaila. And I encourage people, if they come from a background in which it's relevant, to speak to their Rav. I can tell you what the usual answer is. The usual answer that I hear back is, you know, at date number 3, at date number 4, to say something.
To say something.
Now, there are those that, you know, someone that has a severe mental illness,
Right.
someone with schizophrenia. So that's already a different sugya, right? So
that's
there are
level already.
shadchanim that deal with more challenging shidduchim. And there it's wise to be open, because if not, you know, the person goes out and they say, you know, they go out and maybe it goes well, and then they keep getting rejected because it's not, oh, I have anxiety, which is one thing. Half the world is on Zoloft today.
Right.
It's, I have schizophrenia, and people are like, oh my God, and they should react
Right.
in a measured, reasonable way. So the more serious illnesses, I think it's probably wise to be more open about it. But again, it's usually, if it's appropriate from where the person's coming from, it's usually a good conversation to have with one's Rav. And then there's even when people say there's the problem that they're not so transparent about it. So it's, well, I'm selling the car as is,
Right. Yeah.
and your headache if there's a problem.
Right.
We don't do that with our kids.
Now, as far as from a doctor's point of view, would you recommend that two people, a boy and a girl, that is one is suffering from schizophrenia and one is suffering from borderline, should you have a special shotgun that is going to put, just like you put two physical problems together? A lot of times you see that. Should they do this in mental health as well?
So it's interesting. This comes up frequently. And I think a lot of times what people try to do is to take someone with a certain medical condition and someone that has a psychiatric condition and put them together. But we have to be very mindful about something. There's always a concern about, well, if I take two people that have the same diagnosis, the same psychiatric diagnosis, well, that means that their kids are going to be, oh my God, right? So statistics are not koach nevuah. Statistics mean that if I take 1,000 people, the numbers are going to play out a certain way.
Right.
You need huge numbers, right? I have 5 biological kids and 2 stepkids, okay? The sach hakol is 6 boys and 1 girl. According to statistics, it should be 3.5 and 3.5, Hashem Yerachem, or 3 and 4. Okay, so if I had 1,000 kids, then it would be 500 and 500,
Right.
So you got to be careful. Because we, most of the time, even, the largest of families that I've seen, 14 kids, 16 kids, I've heard about 20, 21 kids, but we all need to cool it when it comes to the statistics.
Right.
It requires an individual conversation about looking at this family and that family and how much of the problem seems to be there. And, there needs to be an educated conversation that's had, but it's not an automatic no. And people have to stop making that the most important thing. There's still the midot of the boy and the girl and the families and whether they mix or not. There are so many factors, but, people just get fixated on this. And sometimes it's worthy of being fixated on, but many times it isn't. Just like some medical conditions are worthy of being fixated on, and some are less of an issue.
What message do you have for parents who are afraid to give medication to their kids? They're afraid of the side effects. They're afraid of the growth of the child. They're just so against it with such a passion that is beyond words.
I prefer to work with individuals and parents that are hesitant to give medicine than those that think that the solution to every problem lies in a pill bottle. I think that every time a prescription is written, it needs to be done thoughtfully. I think there are lots of instances where medications are overprescribed, and people should be extremely cautious, just like they're cautious with everything else in medicine. You need to question, do I need to give this medicine or that medicine also in the field of psychiatry? But if it makes sense, then sometimes you got to do what you got to do. Our job, I tell parents all the time, our job as parents across every culture, across every religion just about, is you're given this beautiful little present, and it's your job to turn that beautiful present into a productive member of society. The definition of productive member of society varies from culture to culture. But that's our job. And there are different impediments that come up along the way. And it's our job to deal with them. And there are some kids that will need extra tutoring, and some kids that will need, leg braces, and some kids that need physical therapy. And there are some kids that need psychotherapy, and some kids that need medication. And failing to do so, if it's warranted, has staggering implications. We don't prescribe so easily, at least not in the psychiatric world. We're not supposed to. And people always have to ask themselves, what are the risks versus the benefits versus the cost of doing nothing?
Right.
So if we talk about ADHD very quickly, in a kid, so we know that very young kids between the ages of 3 and 5, that in some of those kids, very intense behavior therapy can be very, very effective for ADHD. But after that, if you're not giving them medication, you're really doing them a disservice if they really have ADHD. Not every kid that struggles with their learning or that has a hard time sitting or that has behavior issues has ADHD. We come back to the importance of a diagnosis and the right label. But if the diagnosis is done by someone who's qualified to make the diagnosis and it's done properly, then not giving the kid medicine for ADHD is absolutely, positively doing them a tremendous disservice. They have higher rates of addiction. Doctors like me see, kids having much higher rates of going off the derech. It's heartbreaking. Wow. It's heartbreaking. Kids that with ADHD in very frum or frim settings, especially the boys, if they're not able to learn well, eventually it really, playing sports goes so far. So if you're not able to learn well and you're having bad experiences with your rebbeim and your manal, well, why would you want to be interested in Judaism? Why would you want to? I mean, it's like pushing them off with both hands, like, here you go.
Of course, they're checking out.
So it's really, really horrific when that happens. And parents will bring me their kids, they're teenagers and they're not interested. And, they're on the streets and, I can try, but it's so hard at that point because they're so turned off. It's our job as parents. It's not about us. And, that involves getting, if a kid's struggling, figuring out what it is and addressing it. And if you think that this doctor is nuts because he wants to write a prescription, go for another opinion. Talk to your pediatrician about it. That's the job of the pediatrician. Your pediatrician is your partner in raising your kid. And they're a jack of all trades, a master of some things. Psychiatric medication is not one of them.
But at least take their advice.
They know what's reasonable and what isn't. And if you have legitimate questions, go for another opinion.
Wow.
But don't just ignore it.
Dr. Hizami, you are a guide. You are a lifeline to teens, to children, and to families and individuals. You're getting through people in their darkest times, which is an amazing, amazing thing. May the Rebbeinu Shalom continue to give you clarity, to give you koyach, and to be a messenger, a shliach. That's your shlichus in this world. And you give hope to Klal Yisrael.
Thank you. And I wanted to give you a bracha that eventually the podcast is going to turn from being called The Struggle to being called The Solution.
Excellent.
May you have
I love it.
Tremendous ongoing siyata dishmaya.
Thank you.
You're doing avodat hakodesh here.
Thank you. Thank you. I really appreciate your time, and thank you for coming. Thank you.